Hey everyone, welcome back. In the last PowerPoint, we went over the breast cancer basics, tried to provide you with what I think is some important information to help prepare you then for this content, the breast cancer treatment approaches. Not going to lie, there's a lot of information in these slides, and this is a relatively large topic. So I'm going to break it up into little birdie bites, if you've ever heard that term before, and we'll do our best. But then keep in mind, as we approach any assessment, I'll be pretty specific on what I want you to know, focusing really on the first line approaches to the treatment of the various cancers, right, that fall under this breast cancer umbrella. Today, what we're going to do is we are going to go over our treatment approaches for early stage disease, for locally advanced, and then for metastatic disease. Okay. And it sort of falls into these buckets, which I'll show you a sort of a roadmap for in a moment. Okay. And I think it's important, again, as pharmacists, that we understand why we're using a particular drug combination that we're using. Right? Why are we using a particular regimen in hormone receptor positive disease? Why are we using certain drugs for HER2 positive? Why do we use certain drugs in the triple negative setting? Right? In the locally advanced setting, we have neoadjuvant therapy. In early stage disease and locally advanced, we have adjuvant therapy. So we'll talk about the various regimens that are used for each of the breast cancer settings. And then when we get into the metastatic setting, there's a lot of different treatment approaches. We'll get there, right? We'll get there. The rationale behind what and when with regard to endocrine therapy is circling back to hormone receptor positivity. So we'll touch on that. And along the way, what are the non-hematological side effects that some of these drugs cause? Sort of their dose-limiting toxicities. We'll focus in on that. All right, I don't understand why this renders the way it does. This is not how I wanted this particular image to look, but for whatever reason, all the boxes on the left and right get darkened out. So we'll do our best, okay? Up front, breast cancer. Patient comes in and they're diagnosed with breast cancer. That's unfortunate. What do we do about it? Well, if it's in the right stage, early stage disease or locally advanced, we are going to approach this patient with curative intent. We want to treat that patient to try and cure them of their disease. When we look at an individual with the approach of curative intent, we have to know about the tumor and we have to know about the tumor size. So T, we have to know about nodal involvement, and then we have to know about the absence or presence of metastases. So it's going to be M0 here because we're trying to cure the patient, right? And if it's early stage disease, then that probably means that the tumor is relatively small, less than 2.5 centimeters in greatest diameter, all right? Early stage disease, we typically are going to approach this patient with a surgical procedure, a breast conserving procedure like a lumpectomy, or the patient's going to get a mastectomy. That's sort of up to them. Okay. After surgery, we are going to follow that up with adjuvant therapy. Adjuvant therapy is what we give after a patient has had a definitive treatment approach, being the surgery here. Now, how do we know what adjuvant therapy we are going to give our patient? Well, that's where it comes back to the tumor characteristics. We need to know about the type of tumor that patient has in order to inform our decision on the appropriate adjuvant therapy. If the patient has a tumor which is hormone receptor positive, after surgery, we are typically going to give that patient endocrine therapy. All right. We're going to typically give them some form of endocrine therapy, whether it is an aromatase inhibitor, whether it is an estrogen receptor antagonist, that's the type of drug that we're going to give that patient who has hormone receptor positive cancer in the adjuvant setting for early stage disease. However, there's certain patients in this same track that have sort of a high risk tumor, right? It's hormone receptor positive, but the tumor has revealed that it is likely to come back if we don't take the appropriate measures, right? We know that based on the Oncotype DX assay, which is a genetic assay that we'll talk about. And the Oncotype DX assay tells us whether or not we need to give that patient chemotherapy plus endocrine therapy as part of their adjuvant regimen. Okay. All right. If the patient has early stage disease, undergoes a surgical procedure, and then they have a HER2 positive cancer, we are basically going to give that patient adjuvant chemotherapy plus a HER2 directed agent. Right? And if that patient has a triple negative cancer in the adjuvant setting, we are going to give that patient chemotherapy as their adjuvant treatment. Then we're learning more and more about the benefits of PARP inhibitors if the patient has a germline BRCA mutation. And we'll talk more about that as we move forward. Okay, so again, curative intent, early stage disease, surgical procedure, and then adjuvant therapy based on the characteristics of the tumor. Keep in mind, too, we also pay attention to the patient. Curative intent with a locally advanced cancer. Locally advanced means a larger tumor or regional nodal involvement, like N1 disease, where there's 1 to 3 nodes involved, or N2 disease, where there might actually be a little bit more nodal involvement. Since these are larger tumors, they can often be difficult to sort of perform a surgical procedure on. A lot of these masses can be spiculated. They have a lot of, for lack of a better word, tentacles emitting from them. So what is often done is neoadjuvant treatment. Here, the patient is going to get some type of regimen before they go to the OR to have a surgical procedure. And there are a variety of different neoadjuvant regimens that have been studied and that are listed in the guidelines. So how do you know what neoadjuvant regimen is appropriate for your patient? Well, it kind of harkens back to what we just got done talking about in the adjuvant setting for early stage disease. We have to know about the tumor characteristics. Now, if we know that our patient has a triple negative breast cancer and we want to give them neoadjuvant treatment, it's most likely going to be chemo. However, there's some evidence out there to suggest that immunotherapy is beneficial here in combination with chemotherapy. So that's going to be an option. If your patient has HER2 positive breast cancer, in the neoadjuvant setting, excuse me, we are going to use chemotherapy, but we're also going to add on HER2-directed monoclonal antibodies, such as trastuzumab. And if it's large enough and aggressive enough, we can add on pertuzumab. What do we use in the neoadjuvant setting for hormone receptor positive breast cancer? Well, you would think that we would use endocrine therapy, but in fact, what's recommended is to use chemotherapy. Right? We use chemotherapy as the neoadjuvant regimen for hormone receptor positive cancers. Remember, we want to, as aggressively as possible, shrink the size of this tumor down to next to nothing. And then when that patient goes to the OR, when they open her up and look, they don't want to see any evidence of cancer. They want a pathological complete response. We can perhaps get to that point much sooner as well with chemotherapy in the hormone receptor positive setting as compared to with endocrine therapy. Endocrine therapy takes time. It takes a lot of time, right? So nonetheless, we give them neoadjuvant therapy. We shrink that tumor down. We afford the patient then the ability to have a lumpectomy over a mastectomy. And then we have to make considerations for adjuvant therapy in the locally advanced setting. And there's a lot of variability here depending on the tumor characteristics. Okay. The last thing I'll mention is then metastatic disease. All right. Metastatic disease suggests that the primary has left its site and it's in the bone, it's in the brain, it's in the liver, it's in the lungs, what have you. Okay. And there are many different treatment approaches to metastatic breast cancer. But what I can tell you is that you need to know the tumor characteristics. You need to know what type of breast cancer that patient has in order to inform your decision on what the appropriate palliative approach is for metastatic breast cancer. Okay. And we will go over these individually. I'm not going to spend time sitting here talking about every single box, but if you were paying attention to what we do here in the early stage and locally advanced setting, you can almost predict then what we do in the metastatic setting. And by example, if it's hormone receptor positive, we're going to use endocrine therapy, but we're going to use endocrine therapy plus a cyclin-dependent kinase inhibitor. All right. If it's HER2 positive metastatic disease, we're going to use HER2 directed therapy plus chemo. All right. If it's triple negative, well, we would typically use chemotherapy, single agent chemotherapy. We might use a PARP inhibitor like olaparib, but there is new evidence that has come out in the last couple of years to suggest that immunotherapy plus chemotherapy has benefit for certain patients that have the right biomarker. And then there are other immunotherapies that could be used as well for the triple negative setting. All right. So we'll consider all of these individually as we move forward. Okay. All right. Treatment approaches, again, not trying to be redundant, but it does depend on stage, and we just went over that. Early stage, locally advanced, and metastatic. It does depend on tumor characteristics. So I need you to sort of compartmentalize these tumor characteristics. All right. Hormone receptor positive, HER2 positive, all right. Triple negative breast cancer. Okay. I need you to wrap your head around those three types of tumors, if you will. We also do need to consider, is this patient presenting with de novo disease? Is this the first time? Are they having disease progression such that we're going to look at a second and third line regimen? Is this a recurrence? Is this a recurrence locally or is it a distant metastatic recurrence? Right? What prior treatments did they have? And when we talk about prior treatments, we also need to consider how long has it been since that regimen ceased? Did it come back within 6 months or has it been, 6 years? Because that can predict whether or not that recurrence is going to respond to the same regimen or not. And then importantly, you've heard this term already before, performance status. How is your patient? What's their overall health? What does their overall comorbidity status look like? Okay. Do they have a good performance status as indicated by a lower number, 0 or 1? Or are they doing not so great? And when they have a performance status of 3 or gosh, even 4 for that matter, you have to be very, very careful about how you go about treating these individuals because you don't want to do more harm than good with your treatment. So we need to be cognizant of their ECOG score or their performance status. So early stage disease, I sort of already mentioned that. And early stage disease is sort of, you could maybe draw a line sort of through here. Locally advanced disease is sort of here all the way down through here, and then metastatic disease. Again, metastatic disease, any tumor size, any nodal involvement, doesn't matter. You could have a small primary and no nodes, but if you have a lesion in the bone, that's metastatic disease, right? Early stage disease, surgery is the best treatment approach, mastectomy or a lumpectomy, and then we follow it up with adjuvant therapy. If it's locally advanced, if the patient is a candidate for neoadjuvant therapy, we can go in and put that patient through several cycles of neoadjuvant chemotherapy, shrink that tumor down, and then we might be able to afford the patient a lumpectomy as compared to a mastectomy. So we do neoadjuvant therapy, we follow that up with the surgical procedure, and then depending on the type of cancer and the response to the neoadjuvant therapy, we decide on the appropriate adjuvant therapy, right? And then as far as metastatic disease is concerned, again, knowing the tumor characteristics and knowing the patient's performance status helps us make the decision on what we do in that setting, right? All right, we'll stop here, and then when we come back, we'll go ahead and start our discussion on early stage disease.